turn it over to Mike. Thank you.
Thank you, Dr. Cheever.
Thanks very much, Rachel. That was wonderful, and covered a lot of ground. And the Q&A was really digging into a lot of things that I'm getting questions about. So that was nice. So for our anchor leg, as far as the formal presentations today, really pleased to have Dr. Wendy Armstrong here from Emory University. She's been involved in HIV care for quite a while, active in the HIV MA and leadership roles. And today she's going to talk to us about telemedicine, something that because of COVID, we've been engaging in a lot more, and there's a lot of questions and nuances to it. And so we're really happy that Wendy's here to show the light in terms of how to approach this. Wendy.
Well, I'm going to try and show the light. I'm not sure we know where the light is yet, but thank you so much, Dr. Sag, and thank you all for inviting me. So in the next half hour, a little short of that, I'm going to try and tell you a little bit about the challenges and opportunities of telemedicine. I have no financial disclosures. At the end of this presentation, I hope that then you do have an understanding of the advantages and disadvantages of telemedicine, understand the regulations that apply to it, and can list some of the questions that remain. I do have a disclosure, though, or a disclaimer, that our clinic, which is affiliated with a public safety net hospital in Atlanta, has frankly struggled to meaningfully implement many aspects of telecare. And so some of what I'm going to tell you are some of the very real life challenges that we've had. So, telehealth has long been advocated as an opportunity for those of us in HIV care, as a way potentially to reach areas that lack HIV expert providers. And I think the way this has been conceived of previously has been in asynchronous teleconsultation. The Project ECHO was initially begun in New Mexico for HCV care many years ago. And some of you may be familiar, but it's been really wildly successful as an opportunity for providers that lack expertise in a particular area to have really virtual consults with those with expertise. Although these are asynchronous, this is not occurring when the patient is sitting in front of the provider. But this model has been expanded to include HIV and then other chronic diseases and has spread around the country and even internationally. And so that's been sort of the gold standard. It's worked very well in some settings, and the uptake has been less great in other settings. But prior to COVID-19, there wasn't this push for synchronous telemedicine. And the reason for that is that there were significant restrictions on what could be reimbursed. And services could only be reimbursed if they were provided in a particular designated rural area, or if the patient was actually sitting in another healthcare facility. In that case, really, the patient's provider would have to initiate the telemedicine visits. And so because of these restrictions and the absence of reimbursement, there was absolutely no incentive for hospitals or clinics to build systems to accommodate telemedicine. Well, as we all know, this entirely changed when the world entirely changed with COVID-19. And so one of the first things that was passed in March 2020 was HR 6074, the Coronavirus Preparedness and Response Supplemental Appropriations Act. And that, plus some additional waivers, allowed for $8.3 billion of emergency funding for coronavirus. And some of that was carved out for telehealth services during the emergency period. What this also did, though, was it waived Medicare and Medicaid restrictions and requirements during the public health emergency. It provided full reimbursement for telehealth services, both audio or video. And it also allowed there to be reimbursement for patients to see many different types of providers. So it didn't only have to be your primary care provider or only have to be a provider with whom you had a previous relationship. And these visits could happen in the patient's own home. There wasn't a restriction about location. And so this really allowed telehealth or telemedicine to explode. And as we all know, many of us rapidly adopted video or telephone visits during shelter-in-place orders. And I'll show you what happened in our own clinic. And I suspect many of you, your clinics may have been even more robust than ours. You can see here in orange, across the bottom is time by week or half month. In orange, you can see in-clinic visits, and in green are telephonic visits. And you can see in about the end of March, suddenly we shifted from 100% in-clinic visits to about 50-50 with telephonic visits. And then after a few months, we resumed more in-clinic visits, but telephonic visits remained about a quarter of our care. You can see that some of these columns have a tiny nubbin of yellow at the very top. And those were our video visits. And I told you we didn't really successfully deploy that very robustly. And I'll explain why. But at the end of the day, what's not to love about telemedicine? I mean, it solves a lot of the problems that we really struggle with. One of those, one very important problem is stigma. And unfortunately, for many of our patients, it is stigmatizing to have to come to a clinic that's often labeled as an HIV clinic, even if we try and do that euphemistically. And unfortunately, and I hate to admit it, but there are stigmatizing experiences that exist within our clinics for many of our patients. And so protecting our patients from that and allowing them to have their visits through telehealth can be really advantageous. Another huge barrier is transportation. And we know that this consistently is at the top of the list. Our clinic serves a 20 county area. Transportation is a really big deal. And so telehealth solves that. And another thing is that we are constantly discussing how can we better meet patients where they are. And telemedicine helps us do that. It helps the patients choose where they want to take that visit and allows that control and doesn't force patients into our brick and mortar clinic at the times that we prescribe. And so those are a lot of really good things. And another really good thing that I worry about a lot is the fact that we have a crisis with our HIV workforce. We don't have enough HIV experienced clinicians. And so this study was done and published earlier this year by Rose Bono, looking at the Southeast and looking at the rate of HIV experienced clinicians. And each dot that you see on this map is the practice location of an HIV experienced clinician. And their definition was actually a low bar. This was someone who saw at least 10 Medicaid, the patients living with HIV, Medicaid insured or Medicaid, it was their payer source, over the course of 3 years. So 10 patients over 3 years led to the label of being HIV experienced. And you can see that most of these dots are in the light gray part of the map. These are in urban counties that have more than 5 diagnosed HIV cases. And the dark shaded spots with almost no dots are rural counties with more than 5 diagnosed HIV cases. And regardless of the type of county, this is not a very broad swath where there are dots. If you don't like maps, looking at this another way, I think is really striking. And this is from the same paper. These are the 14 states that were studied. And you can see, just look at the red box. This is the median number of HIV experienced patients in rural counties in these listed states. And it's an entire column of zeros. It's 0 is the median number. So we have a massive problem with HIV workforce, and our workforce is not spread evenly out across the country. And telemedicine gives us a tremendous opportunity to address that. Just 2 weeks ago, the Biden administration announced that they were going to fund telehealth in rural America, that they were going to set aside funds to expand the infrastructure for telehealth. And that's actually really welcome news. But again, providing technology isn't the only answer to providing the infrastructure that's necessary to have physicians and other providers available to our patients. So how about patients? What's their feeling about telemedicine? That's obviously key. This is a very often quoted study that came out of the Thomas Street Clinic in Houston. And of note, this is pre-COVID. And they administered a survey to their patients and asked if telehealth were available, would they prefer telehealth to in-person visits? And 57% of their patients said they were more likely to use telehealth if available. And you can see it was a reasonably representative population, 2/3 male, 83% were US born, which is important, and a significant number of Black and Brown patients. But if you look at sort of experience now in COVID, this is data from San Francisco. And after they experienced telehealth, they asked their patients if they preferred in-person visits to telehealth visits or liked them both equally. And you can see that 42% liked the visits equally, but the majority, 47% almost, favored in-person visits to telehealth visits. And so there are patients for whom this is a good option, but not everyone loves this option. This is a slide that I have borrowed from a colleague of mine, Jody Dion at the University of Alabama, Birmingham. And early in the pandemic, she asked her providers and her staff what their feelings were about administering care through telehealth. And these were some of the quotes that they said. They said, telehealth does not work for some of our most vulnerable patients. They have either no phone, no minutes, no camera, no internet, or no private room to talk. You know, you need to put your eyes on patients as maybe the only chance for them to talk with someone about their problems with their partner, their roommate, or their child. Others talked about the challenges establishing strong patient rapport and that being an important purpose of the visit. or that telehealth visits were stressful for older patients that may be less computer savvy. And one just said the whole thing is just weird and awkward. So again, there's mixed feelings. And I think all of this raises a lot more questions than it gives us answers. And I'm sorry that I'm not going to have pat answers for you at the end of this talk. I'm going to have a lot of questions that we need to explore. And so I've tried to split those questions into categories, and I want to spend some time on clinical questions and spend some time on this slide, who benefits the most. So for example, is it for new patients or established patients? I think the gut answer is, boy, established patients make sense. They're already in the clinic. They may already have stable HIV care. They have a relationship with their provider. And so this actually may not be impaired by having telephonic conversations or video conversations. Whereas the new patient you want to spend more time with, you want to establish that rapport, and the physical examination at least once very carefully is very important. But I would say that I've heard more than once about patients who, again, didn't come to in-person intake visits as new patients because of concerns about stigma and anxiety about approaching the clinic. And we're able to keep those appointments through telehealth. And that lowered the barrier to getting into care, into the anxiety that comes with getting into care. So I'm not sure what the right answer is here. Another question is, does age matter? We just talked about how older patients are less likely to have smartphones or laptops, or are less likely to be comfortable with technology. But on the other hand, this is a population that has more trouble with mobility sometimes, and this may benefit that population. Or how about gender? In our clinic, we did a survey and asked our patients after a bit into the epidemic what their feelings were about telehealth. And while most were comfortable with the telephonic visits we were doing, there was a signal among women who said that they were anxious that they were not getting good care because they couldn't be carefully examined. And so is that about touch and the importance of the examination in a visit? Is that about gynecologic exams in women? Is that a gender thing? I don't know the answer. This needs to be looked at and validated. How about the type of visit? I think telehealth offers us some incredible opportunities to check in with our patients more often, to touch them more. We could have adherence visits. And if it was by video, you could even have people show you the bottles of their medications to be sure they're being taken appropriately. Or what about triage for walk-ins? Instead of having people come to clinic, perhaps they could call and we could determine if they need to be seen in person or by video visit or telephonic visit instead. And lastly, what about the type of service that's best for this? I'll say our behavioral health folks have had great luck with telehealth. Is that because physical examination is less important in that service? I don't know. And what about, nutrition and social workers and case management? That might be a very good type of service for telehealth. I think one of the things that concerns us most is that we all know that clinician-patient relationships matter. And I don't know the impact of virtual visits on those relationships. How many times have you seen a patient and you can tell that something's off? Maybe their foot is tapping, maybe it's the look in their eyes, but that there's something being unsaid and you can explore that further in a visit. Or how many times do you have the door handle conversation where it's the thing that they really have been wanting to tell you that happens almost as they leave the room? I'll say when I have telephonic visits with my patients, they tend to be more upbeat and tend to be less likely to tell me about some of those niggling things that are bothering them that don't feel like they reach the threshold of urgent. And so I don't know, again, if this is impaired in a virtual visit or if we just need to learn to do it better. How about care coordination? We're all lucky enough to work in Ryan White clinics that have phenomenal wraparound services built in. And we know that this makes a difference for our patients as far as their success in care. How does that work again in the virtual setting? Because when I see a patient and I discover an unmet need, what I usually do is get up and take that patient to the person that can help them in the clinic environment. And sometimes that's 2 or 3 or 4 or 5 additional visits during that day in order to optimize the wraparound services and help that patient the most. How does that work on the telephone or in the video? How do you coordinate all that? Or are those 2, 3, 4, or 5 separate instances of calling in a virtual setting? What about PrEP? I think that PrEP may be very different than getting longitudinal HIV care. Here's a setting where I don't know if the same level of longitudinal relationship with a provider is as important. I do know that a thorough physical exam is probably less important. And we've had some very successful experiences with teleprep even prior to the pandemic. At Grady, we had a robust teleprep program that was initiated a couple of years before the pandemic that is mostly pharmacist driven and mostly done through telephonic visits with medication delivery and self-swab testing for STIs that's then dropped off back at the clinic. Our group, led by Valeria Cantos, evaluated the effects of mitigation measures during the pandemic. And they found that most of these patients did not have interruptions in care, but many increased their use of medication delivery to the home from 57% to 73%, but did have more interruptions in quarterly labs. The vast majority had no concerns, however, about the ongoing use of telephonic services for care, likely because that was how the program was built pre-COVID. So those are some of the clinical questions. How about system questions? It's hard to change your clinic into one that accommodates telehealth. At least that's been our experience. I mean, the first thing is choosing a platform, and our health system was very anxious for us to use our EMR, Epic, as our platform for video visits. And that's because the billing and documentation was built into the visit. But it's a much more clunky system than Doximity, where you could easily on a smartphone dial up and have a video visit with a patient, or Zoom, where many of our patients were more comfortable with this platform, and frankly, our clinicians were more comfortable with that platform. But with Epic, we found we needed even more support from the clinic schedulers and the clinic navigators and people to be able to call the patients in advance and brainstorm through the IT issues in order to have a smooth day seeing patients through video visits. And honestly, that bandwidth has not been available, that personnel bandwidth hasn't been available, and it has impacted our ability to provide video visits. How about laboratory studies? If you are seeing your patient at their home, it's an extra effort to get in and have labs drawn. Now, for some, this isn't a big barrier. They can probably go to a local LabCorp or Quest and have labs drawn more conveniently, potentially, than coming into clinic. But that's if their payer source accepts that. And that's also if they don't need STI testing, where self-swabs are not accepted at Quest and LabCorp, for example. And for some of our patients, it's actually was more difficult to get into the clinic during the pandemic. And there's no question that the amount of laboratory testing declined. And I think many have had that same experience. Unfortunately, this also all exists in a very complex regulatory environment where there are restrictions and regulations on physician and provider licensure, on billing, and on reimbursement. And these are challenging, and they are constantly now shifting under our feet. So for example, for licensure issues, some states and territories have modified their licensure issues for telehealth in response to the pandemic, but only through the public health emergency. And things are changing again now with many of the loosening and restrictions expiring as we speak. So in some cases, physicians are allowed to see patients across state lines. In some cases, out-of-state physicians are allowed to see patients within our state across state lines. In some cases, there are restrictions on audio only, or on, again, whether there are established provider-patient relationships in advance of the telehealth visit. And so this is different for every single state, and the changes are different for every single state. And this website at the Federation of State Medical Boards is incredibly helpful at listing what is going on with your state and when the public health emergency standards are set to expire. Similarly, telehealth coverage is dictated by the state. The states regulate private payer telehealth laws as well as Medicaid. And then in addition to the states having some regulation, the individual insurance companies also have different regulations for their telehealth, what's allowed in telehealth. Most have been very permissive during the pandemic, waiving cost sharing for COVID and non-COVID visits, setting reimbursement equivalent to in-person rates for services. But most of these have expiration dates that are set in 2021. And so what's going to happen after that is something I think we're waiting to see. CMS regulates Medicare, and they recognize the role that telehealth is playing is different than previously, and have extended there is at least talk of them extending their permissive regulations to 2023, and then taking a large reexamination of where we are with telehealth at that time. Again, this site run by the Center for Connected Health Policy can be very helpful, particularly for the insurance companies, at explaining what their individual practices are. So at the end of the day, as the public health emergency is ending, key questions include whether reimbursement rates for video visits will continue to have parity with in-person visits, and whether there will be decent reimbursement rates at all for telephone-only visits, which in my experience in talking to providers around the country continues to be the most common mechanism for reaching patients virtually. And again, there are changes as we speak in who can practice across state lines. But at the end of the day, the most important question is, does telemedicine impact outcomes, and what are the outcomes? Is the overall quality of care maintained, or is there a difference again with those door handle conversations and relationships? Is virologic suppression maintained? There are a dozen studies out there, some of which show that it is, some of which suggest that it may not be. I think these are all nuanced based on the clinic and the clinic environment and the patient population that is served by each individual site. And we know that virologic suppression isn't the only outcome that matters to our patients, that quality of life is the outcome that really matters to our patients. Are there increased loss to follow-up? If we can tabulate what's happened to virologic suppression, those are the patients that are showing up and that we have numbers for. What about those people that have disappeared and that we aren't following and we don't know where they are? And importantly, does telemedicine drive increased disparities? And here is where I really have some concern. We know there is not digital health equity. We know there is a digital divide. We know that, for example, the rates of smartphone and broadband subscriptions, they are lower in those who are older, in those who are non-white, in those who have lower levels of terminal education, in those with lower income, and those who have rural residents. We also know that for those for whom English is not their first language, this adds another barrier to that visit. Not only is there now a video or telephonic visit, but there is now a virtual interpreter as well, and that can be really challenging. And what really worries me is the lack of private spaces for all of our patients. Some are not out with respect to their status to the people that they live with or in their same home. And some have concerns about intimate partner violence or other kinds of safety issues at home. And so we need to figure out how to provide safe spaces to our patients that may not be their home in order to have telehealth visits. Because at the end of the day, what our real goal is to provide options for our patients. It's to develop differentiated service delivery. It's to have some patients who might want to come into the clinic and have that face-to-face conversation. Some who want to have their visit through telehealth. Some may wish to receive care through mobile integrated health units or home visits or through community supports. And what we need is a menu of options for our patients in order to meet them where they are and serve them best according to their needs. So telemedicine is a really important new tool in the box. We need implementation research to understand how to use it best. We need to solve rather than hide behind digital disparities. I think we shouldn't just X out individuals who are more vulnerable or who don't have broadband and say that this is not an option for them. That reminds me a little bit of when we used to say we shouldn't roll out ART to sub-Saharan Africa because there were fewer refrigerators and watches for patients to take their meds well. That wasn't the answer, that was the wrong answer. And the wrong answer for us is to say that this population that may benefit just simply can't have it. But we need to stay vigilant for all kinds of widening disparities that we may hide or miss in this rollout. Telemedicine will not work for everyone. Nothing works for everyone. That's the point of having tools in the box to sort out what's best. And thanks to Dr. Bender-Ignacio for pointing out this paper at the end of her talk. I also have it planned at the end of my talk, that this is a paper that we wrote with others of our HIV/MA colleagues talking about innovations that were developed during COVID that should be maintained and move forward. And I clipped out here the telehealth section for the policies that are necessary for us to make telehealth robust. And it includes many of the things we've discussed about reimbursement, facilitating across state lines care. Advanced practice providers should be able to deliver telehealth without additional licensing requirements. Asynchronous services like Project Echo, we have to figure out how to fund those not on night and weekend time for our expert HIV providers. And that I think is really important. We need to be sure that telehealth is part of retention and care metrics and that there's adequate funds to expand the infrastructure for our patients. And we need to do implementation work and understand what the balance is between in-person and telehealth visits. I'd like to close with a few acknowledgements. My colleagues at HIV-MA have been incredibly helpful in discussions about this. I'd like to particularly call out Marwan Haddad, who I spent a long time talking to about what works for him in Connecticut in a very different environment than Georgia, as well as Allison Agwu. These two had a terrific debate on telemedicine at ID Week only a few days ago. And if you have the opportunity to stream it, it's entirely worth it. I'd like to acknowledge my colleagues and staff at the Pont Center at Grady Health System, particularly Jonathan Colasanti and Jerry Sumitani, as well as our teleprep folks, Valeria Kentos and Meredith Laura, and the teams that I work with. And I will close there and be happy to take some questions.
Thank you so much, Wendy. Great review. And actually, the questions that came in while you were talking, you hit a lot of them. So, but I'm going to go back and bring them up. So one came in from Christine Bender, who's saying that in her experience, the barriers, the regulatory barriers, are more regional and local. And the only thing that really seems to be nationwide is the Medicare restrictions, but licensing boards are different. And she, I think, found that at least in her locale, Medicaid was pretty good as far as accepting this. My question off of that, and you can comment on her thoughts as well, is how can we, if it was important enough for us to relax regulations for COVID, it seems important enough that we relax it for rural health. And I know that's what the administration proposed, but why would we go back to what was there before after COVID gets a little better?
Yeah, no, I wish I had a sane answer for that. I can't imagine why we would go back at this time. I think it's the wrong answer. And I think it's going to take advocacy. People are clearly tuned into telehealth. And it is clearly part of a conversation that hasn't happened before. And I think advocacy can change this. I don't think there are all that many downsides for individuals, but I do think it's going to take bringing it to attention and keeping it part of the national conversation. I know Allison, for example, Agwu just told me this past week that she just got a notice that she'd no longer be able to see patients in the DC area from her Baltimore office. And so this is happening and they are rolling back now. And we need to be sure that people are aware of that so that there can be a push. Like I say, Medicare is taking a lead here and is saying, this is important and we need to relook at it a few years hence. I suspect we can make progress on the other payers.
Right. I have a question here from Michael Hendricks, who's talking about that a lot of his patients don't have equipment. He went through that a little bit, but also raised the question of, even for those that do, how do we deal with lab? How do we deal with other things? You mentioned going to many of your colleagues when an issue pops up, but just something as simple as lab.
Yeah, labs are tough. And I think that it's going to be hard to provide options for patients who do not have private insurance to have labs done that are outside of them popping into clinic at some point, to have them drawn or popping into other areas within the health system that serves you, that has multiple sites. I do think that we're making progress on STI, home STI testing kits, at least in the PrEP space. And I wonder if that is one thing that can be exported into the HIV care space as well. Because for most of our controlled patients, the frequency of viral loads and CD4 counts has gotten pretty minimal. And so I do think it's some of these other issues like STI testing that worry me the most, frankly.
Yeah. Monica Mandahar is talking about that a little bit, about recommendations for giving sensitive diagnoses through telehealth. For example, let's say somebody came in, maybe they're at PrEP, but just came in and got tested for HIV. The result comes back positive. Is that something that you think can be done successfully or in a way that's sensitive enough through a telehealth visit?
I do. And I actually think I think telehealth is vastly better than some of the other options. Like right now, for example, as labs are being released almost instantly when they're done, your patient can sign on to their patient portal and discover their HIV test without having any kind of conversation. Or there are home testing kits, of course, which are important. And so people can find out without having the opportunity to discuss this with someone. I think that sometimes trying to get somebody in person actually enhances the anxiety. I think when you call somebody and you say, I have a test result, I'm not going to tell you, you have to come in and we're going to talk about it. I think they know what's going on. And I think being able to actually have those conversations immediately and reassure someone that you are there for them and they are welcome to come in and have an in-person discussion, I think that's actually good practice.
Yeah, we have an important test result. And if you can come in 3 weeks from now, happy to talk to you about it.
Exactly.
Stephen Lahner was wanting to know, coming back to point of care, is there a way from either PrEP or other places that we can do point of care HIV testing, maybe at the time of the visit, some of that technology? I know Rafi will probably talk about this in the PrEP discussion, but are you aware of anything right now?
For point of care testing with
For
clinics
HIV,
or at
just,
home?
yeah, like for viral at home.
Oh, for viral load?
Yeah, and that type of thing.
I can't wait until we can do HIV viral load testing as point of care. I think that's going to be huge. I think there is discussion about that. I'm going to have to leave it to Rafi to tell us where we are. It's certainly not immediately available right now, but I think, but certainly it has been trialed in places. And I think it's a game changer to be able to have tell your patient your point of care test for your HIV viral load shows that you're undetectable.
Right, and I've seen some of the technology for sub-Saharan Africa that's been tested. It hadn't been released kind of for prime time yet.
Right.
A couple other questions. Lorraine Torella is asking about those data that you referred to about outcomes. You said they kind of vary. It depends on the population. Is there any, I guess the general sense is that for those who like telehealth, it works pretty well?
Yeah, I think that none of the studies that I've seen have actually diced it to say, to know who that population is. Like, could people opt in and get telehealth? So where's it a self-selected population? What I've seen are really clinic-wide results. And so I don't know details about how those have been selected. And I've seen that there are, positive results often in places like Boston and San Francisco and so on that have a lot of infrastructure, and less rosy results in places that have a little bit less infrastructure. And so I don't know, I suspect that the patients who like it do well in it, but I haven't seen data that granular.
Yeah, and this next question gets to that. There is a patient that one of our providers is writing about who had experience with telehealth and liked it so much that I don't really want to come in anymore for an in-person visit. I'm sure you may have seen something similar. What's your reaction to that? Is there a certain number of in-person visits over a unit time that probably needed to augment what we do over telehealth?
The physician in me wants to say yes to that at some point you should lay eyes on a person, although I don't want that to become a barrier to actually giving care to someone if the only way that they're going to see you is through telehealth. I will say, for as many people as I've seen say that, and that might be a single person, I've had a flood of people say to me, I am so glad to see you in person again. I really missed this. So I think at the end of the day, for most people, it's going to be a mix of telehealth and in-person visits. I think that's where we'll fall out.
Yeah, Manoj Ray, who's one of our former fellows, is out here. The West Coast just was basically in a very, you can look at what his comment on the Q&A, but basically said this is working extremely well and that he wants to see the momentum continue. We got about a minute left. Maybe you can wrap up and just predict what you think the future will be. And I'd like to hear a little bit more about the licensure issues, because we all have patients who come to us from out of state. When they're in our clinic, it's no problem. If we telehealth, we're suddenly committing a federal crime. What's your feeling about all that and where we're going to be, say, 2 years from now?
I think it's a huge problem. And interestingly, in Georgia, for example, there's felt to be such a dearth of providers that even pre-COVID, there was a law passed that allows any out-of-state physician to take care of our patients in our state. But the converse is not true, that we can see patients across state lines. So go figure. How can you predict state politics? I do think in small states like Maryland and the East Coast and so on, There's going to be a very strong argument to be able to see people across state lines because the state lines are so restrictive. I think in bigger states with large rural areas, it might be actually harder to get some of those permissive regulations passed.
Yeah, I've done these types of things long enough that I'm suppressing a couple of my political answers. You can put a little bubble above my head and try to guess what I'm thinking, but we do have to wrap up. We're out of time. Dr. Armstrong, that was fabulous. You hit all the high points and I think set the stage very well as we are coming out of COVID, hopefully, and but we can have a legacy, maybe some silver lining to dealing with COVID that introduced us more to telehealth when we were sort of in a pre-contemplative state before we were kind of thrown into it. I think you did a great job of summarizing that. Thanks so much. And thanks for your advocacy.
Thanks.
You've done a wonderful job through HFVMA and IDSA and other venues to really help us push the field forward. So grateful for that.
Thank you so much. We need to keep doing this as HIV providers.
Absolutely.